Good morning, everybody. Once again, the first Sunday morning of every month since last 1.5 years, we have been able to regularly do the IHRS DNB arrhythmia teaching program, meant largely for the cardiology postgraduates training all over the country in varied circumstances, varying learning possibilities. And the IHRS conceived that we should have such a program that will discuss some of the basics that could be useful to them in practice as they move towards their exit exams. And thankfully, we have always had willing faculty from different centers all over India, not necessarily only university hospitals, but also good teachers of arrhythmia and heart failure from the private practices in the country who have been willingly coming on with their team. And the idea was to have some didactics, but also have some case presentations and try to involve the postgraduates from that particular center so that the postgraduates attending don't feel intimidated and see their colleagues presenting and the esteemed moderators giving some simple. So it's probably like your ward rounds, only thing with Zoom, we can reach so many people. So once again, I don't want to stand between you and the faculty from Amrita Kochi. I understand that's one of the cardiology postgraduate training centers where many of you like to go. And therefore, this time we thought that we'll involve Dr. Natarajan's team. He'll introduce, he willingly agreed to do such a program and keep it focused on supraventricular tachycardias, which is again, as I have said, a very bread and butter topic for the cardiology postgraduates. And we'll wind up with 2 cases on the CIDs or implantable electrical devices. So without much ado, all the past programs are available on the IHRS website, thanks to our secretary, Dr. Vanita Arora, a very meticulous person. You can always visit those past programs, but for now, let's enjoy and learn from what Dr. Natarajan's team has to say. As moderators, this time we have Dr. Praveen Pai from Amrita, we have Dr. Sharda, and we have Dr. Bhagirat. Both of them very much involved with this kind of work, and I'm sure they'll offer some comments and make you guys comfortable and give you a good learning experience. Natarajan, let the program start.
Thank you, Dr. Ashish, for the kind introduction. Can you hear me?
Yes, very well.
At the outset, I thank the Indian Heart Rhythm Society and Dr. Ashish and Dr. Yash for having given us the opportunity to present cases from our institution. As already mentioned by Dr. Ashish, the very philosophy of this exercise, this monthly teaching program, is to initiate the understanding of electrophysiology in the minds of postgraduates, because most of the postgraduates feel, as Dr. Ashish very correctly said, intimidated by the word electrophysiology. It's not such a intimidating exercise. I'm sure Dr. Sarada and others also will agree with me. So this is essentially, we have 5 of our final year DMPGs who have been asked to present these cases. And I have to accept that all the 5 PGs were thankful that this program gave an opportunity for them to actually understand a little bit of electrophysiology in the last couple of weeks' time when we were tutoring them to present these cases. So with that introduction, we will go forward. Dr. Sarada, my good friend Dr. Sarada, for more than 2.5 years before we
Arey shit!
I'm Namita, can we mute everybody, and then we should have only myself, the 2 moderators, Dr. Natarajan, the 3 moderators, Dr. Natarajan, and the speaking faculty or
done.
Around. Yeah. So the one who is speaking may unmute himself. So Dr. Natarajan, your presentation first.
Yeah. So Dr. Ashish felt that because we are going to discuss about supraventricular tachycardia, the common problems will be to distinguish one versus the other. So he suggested that we will set the ball rolling or create a foundation for the rest of the program by having some basics about some of the maneuvers that we commonly employ in difficult to diagnose supraventricular tachycardia. Oftentimes the diagnosis is quite obvious. When the diagnosis is not obvious and confusing, we resort to some EP maneuvers And this talk will be a 15-minute talk to focus on some of these important maneuvers. I'll just share my screen. You're able to see?
Yeah.
Right. Thank you. So in the next 15 minutes, we will just briefly touch upon some of the commonly employed maneuvers. It is not a complete presentation. Some of the common things that we do in the EP lab to distinguish one SVT versus the other, which is very important for us to make a right diagnosis, and that sets the foundation for an appropriate ablation. So the supraventricular tachycardia, the common ones are AV nodal reentry tachycardia, AV reentry tachycardia, either orthodromic or antidromic, mediated by accessory pathway, and of course atrial tachycardia. The other uncommon forms are the atriofascicular pathway and other not so common pathways, and junctional tachycardia. The diagnosis may at times be very straightforward. When you don't have to do these maneuvers, you can straight away diagnose and straight away ablate the arrhythmia substrate without having to do all these maneuvers, because the diagnosis can be very straightforward. Like for example, if there is a regular narrow QRS tachycardia with a 1-to-1 VA relationship with a very narrow septal VA time, when there is a dual AV node physiology, tachy initiation with a critical prolongation of the AH interval, otherwise called the AH jump, termination with the non-premature A, the diagnosis is fairly straightforward here. It is a typical AV nodal reentry. You don't have to do any extra maneuvers to further differentiate it from other arrhythmias, because the diagnosis is pretty straightforward. Like you see here, this is an atrial extra stimulus delivered after a drivetrain, otherwise called the programmed electrical stimulation, and the AH interval is 212 here. When we make the prematurity less by 10 milliseconds, from the AH interval of 212, it jumps to 270 by a factor more than 50. So we call this dual AV node physiology, or an AH jump. And subsequently, the tachycardia is initiated here. You can see that the tachycardia is induced in the right side of the panel. So there is AH jump, and after the jump, there is a tachycardia initiation. So this is fairly typical of typical AV nodal reentry, and you don't have to do extra maneuvers. Likewise, if somebody has a baseline pre-excitation, or if there is an eccentric VA conduction during V pacing, let us say the earliest A during V pacing is in the distal coronary sinus. And during tachycardia also, you have a similar sequence of eccentric VA conduction with earliest A during tachycardia also in the distal coronary sinus. You know that you are dealing with a left-sided accessory pathway mediated orthodromic AV reentrant tachycardia. You don't need any further maneuvers to differentiate. As you can see here, during V pacing, it is earliest in the distal coronary sinus, distal to proximal coronary sinus, and then the His bundle and the right atrium you can see here. So this is clearly an eccentric activation through a left-sided accessory pathway, and the right side of the panel, the tachycardia has been induced, and you see a similar distal to proximal coronary sinus activation far ahead of the other locations in the atrium. So you know that you're dealing with a left-sided accessory pathway, and you don't need further maneuvers in this particular case. And the third example, you have an eccentric atrial activation. Let's say the earliest activation is in the right atrium, and the atrial activity outnumbers the ventricular activity, meaning there are more atrial activity than ventricular activity. The tachycardia terminates with a V, let's say, and if the VA conduction during V pacing, if it is absent, there is no VA conduction at all, or even if it is present, during V pacing, the activation sequence will be different from that during the tachycardia. You have warming up at initiation, you have cooling off before termination. All these are features very typical of atrial tachycardia, and you don't need to resort to any EP maneuvers to further differentiate. So when the diagnosis is very straightforward, there is no need to split hair and do maneuvers to further differentiate. Moving on from there, when do you need differential diagnosis of SVT in the EP lab? The general principle in EP maneuvers is ventricular pacing maneuvers are often done for narrow QRS tachycardia, and atrial pacing maneuvers are done for broad QRS tachycardia. For the purpose of today's discussion, we'll restrict it to the common narrow QRS tachycardia, because I want to take this opportunity to make the postgraduates understand basic concepts in commonly employed EP maneuvers. So we'll stick to narrow QRS tachycardia. So narrow QRS tachycardia with 1-to-1 relationship between the atrium and the ventricle, there can be occasional confusions. The questions that we have to answer are, is it AV nodal reentry tachycardia? Is it AV reentrant tachycardia mediated by a concealed accessory pathway? Is it atrial tachycardia? Is it junctional tachycardia or AV nodal reentry? These are some of the questions that we have when the diagnosis is not very straightforward, like the previous 3 examples that I just said. So how do we differentiate? Analysis of basal sinus rhythm recordings. Let's say if there is pre-excitation and a short HV interval. All these things will be further re-emphasized in the cases that we present. So the baseline ECG itself gives you a clue to the presence of a pre-excitation when you know that you are dealing with probably an AV reentrant tachycardia. Analysis of the VA conduction during V pacing, whether there is VA conduction at all, and if it is present, is it a concentric or a central activation mediated by the normal conduction pathway itself, or whether it is eccentric mediated by a right free wall or a left free wall axillary pathway. Is the VA conduction decremental, which is very typical of AV nodal or normal AV conduction system mediated VA conduction, or is it non-decremental, which is very typical of accessory pathway conduction? All these are helpful maneuvers to understand the diagnosis. Analysis of the tachycardia ECG, septal VA timing. Short septal VA is very typical of typical AV nodal reentry, for instance. The atrial activation sequence during the tachycardia, and of course, pacing maneuvers, which will be the focus of the talk in the next 10 minutes or so. Entrainment during tachycardia. As I told you, when there is a narrow QRS tachycardia, you pace the ventricle at a rate faster than the tachycardia. And if you can entrain the tachycardia, meaning acceleration of the atrial rate to match that of the ventricular rate, that is called atrial entrainment. So if you can entrain a narrow QRS tachycardia by faster ventricular pacing, that will give you a clue. And ventricular extra stimulus delivered in time with His refractoriness. If you give a ventricular extra stimulus when the His bundle is refractory during a tachycardia, that also can be useful to make a diagnosis, about which we shall talk about in the next few slides. Parahesian pacing during sinus rhythm. If you pace the region of the His bundle, and that will be useful to differentiate between a nodal conduction versus a paraseptal accessory pathway related retrograde conduction. That also is very useful when there is a diagnostic confusion between an anteroseptal accessory pathway mediated tachycardia versus AV nodal reentry tachycardia in difficult cases. Of course, timed atrial extra stimulus can be used to differentiate junctional tachycardia versus AV nodal reentry, about which we will not discuss in detail. So we will basically go through entrainment of a narrow QRS tachycardia by faster ventricular pacing. What is the importance of delivery of a timed ventricular extra stimulus at the time when the His bundle is refractory during tachycardia, and a few words about parahesian pacing, which is done during sinus rhythm, pacing the His bundle region to differentiate between AV nodal reentry versus an anteroseptal accessory pathway mediated AV reentrant tachycardia. We'll concentrate on these 3 particular maneuvers. Baseline ventricular pacing, I already said. Here is an example where the ventricle is getting paced, but there is no VA conduction. So VA conduction, if it is absent, it rules out an accessory pathway, especially if it is, even after isoprenaline, you are not able to have a VA conduction. It is likely that you are not dealing with an accessory pathway. And if there is no VA conduction, it favors the diagnosis of an atrial tachycardia. Yes?
Rajan, sorry, I just joined in a little late. Yash Lokhandwala.
Yes.
Natarajan, just one, I had one request. Can you, when you describe these tracings, can you, for some of the residents will not have any exposure to EP. So if you could just point out where is the A wave, where is the QRS, even for a simple thing like, no VA conduction or VA conduction. I think if you could go a little slow and just point out, it may make people understand better.
Okay, I'll do that. So thank you, Dr. Yash, for that suggestion. So here we are pacing the ventricle. As you can see here, there is a ventricular pacing spike, and you're capturing the ventricle here. You have a broad QRS complex, which is very typical of ventricular pacing. And this is the HRA catheter that you see here. This pink color electrograms are from the right atrium. This is from the His bundle distal, His bundle proximal, and the yellow here is right ventricle. So you have the right atrium on top, the right ventricle below, and the white tracings is of the His bundle. So we are pacing the ventricle now. And the question that we are answering now is there VA conduction present or not? If there is VA conduction, after every V that you see here, you will have an atrial activity matching that of the ventricular pacing rate. So if you see here, the atrium is here and the ventricle is here, and the ventricle is not followed by an atrial activity. The atrium is by the sinus rhythm itself, and the ventricle is not able to engage in the retrograde direction. So the answer to the question, if there is VA conduction in this particular tracing, there is no VA conduction. The absence of VA conduction, especially after isoprenaline, fairly rules out the diagnosis of accessory pathway being part of the tachycardia substrate. And it favors the diagnosis of an atrial tachycardia because the atrial tachycardia does not need VA conduction for its continuance. Is that okay, Dr. Yash?
Yes.
Okay.
Yes, Natarajan, that is much better because I understand that we are going to varying grades of people, but some are very raw in this, so they'll get overawed otherwise. That's why.
Sure. Thank you. So now look at this particular example. We are pacing the ventricle once again, but every ventricular activity is followed by atrial activity. Here the green signals are from the coronary sinus, from distal to proximal, distal coronary sinus, and this is the proximal coronary sinus. For every ventricular pacing, there is a proportionate atrial activity because there is ventriculo-atrial conduction. And if I ask you the question, which among the atrial locations is the earliest atrial recording made? It is in the distal coronary sinus in this case. These catheters are labeled from distal to proximal. 1-2 is distal, 9-2 is proximal coronary sinus. So when there is a distal to proximal coronary activation sequence with the 1-to-1 VA conduction as is shown here, it is likely that the ventricle the ventricular pacing impulse has been able to engage the atrium through a left lateral accessory pathway because the CS catheter is in the coronary sinus, and the deep in the coronary sinus is the left mitral annulus epicardial. So if there is a 1-to-1 VA relationship, as in this case, look at where it is earliest seen, it is in the distal coronary sinus, and so our VA conduction is likely to be through a left-sided accessory pathway. And if you look at this example, here we are pacing the ventricle, as you can see, broad QRS complexes after the spike here. That is the ventricular electrogram immediately after the spike. So we are pacing the ventricle here. After a drive train, we are giving an extra stimulus. You see that this pacing interval is shorter than the drive train. So this is called ventricular extra stimulus protocol. And I want you to see the VA conduction here. During the drive train, you see a VA conduction. There is near simultaneous activation of all the atrial locations here. We call this concentric ventricular atrial conduction, mediated probably by the normal AV conduction system itself. So there is VA here, there is VA here, there is VA here. But you look at the VA interval here. The VA interval is longer as compared to the drive train, as you can see here, with an extra stimulus prematurity of 330. When you give an extra stimulus with 10 milliseconds more prematurity, you look at the VA interval here. You look at the VA interval here, and you look at the VA interval here. This is what is called the concentric decremental VA conduction. As we know, the AV node, one of the important conduction properties of the AV node is decremental conduction at faster rates. If you pace the AV node faster, the AV node becomes slower in conduction, either from the atrium to ventricle, as well as from the ventricle to the atrium, as you can see here. So this, if it is present, you are dealing with probably a normal AV conduction related retrograde conduction pathway, and likely that this patient has a typical AV nodal reentry. Specific pacing maneuvers. Let us now discuss a few words about ventricular entrainment pacing, wherein you pace the ventricle a little faster than the tachycardia itself. And we'll also touch upon his refractory PVC as well as para-ischian pacing if time permits. Let us now look at what is ventricular entrainment pacing during supraventricular tachycardia. This is a quick way to differentiate the common forms of SPT, that is AV nodal reentry, AV reentry, and atrial tachycardia. How does it help us? You have to pace the ventricle a little faster than the tachycardia. And how do you have to first confirm entrainment? Whenever you are successfully entraining a tachycardia, by ventricular pacing, the atrial rate accelerates to that of the ventricular pacing cycle length. Only then you say that the tachycardia is entrained. And once you stop the pacing abruptly, the tachycardia should ideally continue. And this gives you an opportunity to look at an important observation that you can see here. As I told you, you confirm entrainment when the atrial rate accelerates to that of the pacing rate. Only then you have entrained. And upon termination of RV pacing, you look at what happens next. You have a ventricular activity, an atrial activity, followed by a ventricular activity. We call it as a VAV response, which is very typical of AV nodal reentry as well as AV reentry through an accessory pathway. In contrast, if you have one V and two atrial electrograms and then the next V, we call it a VAAV response, which is very typical of an atrial tachycardia. So this maneuver quickly tells you whether you are dealing with an AV nodal reentry, AV-RT, versus an atrial tachycardia when the diagnosis is in doubt. Of course, you can look at some quantitative measures like PPI minus tachycardia cycle length. PPI stands for post-pacing interval. And STIM to A versus V to A during tachycardia. These are some quantitative parameters which will also help to differentiate between an atrial AV nodal reentry from an AV reentry tachycardia. So what are the possible responses that you can get by ventricular entrainment during a supraventricular tachycardia? Response number 1, there is no acceleration of the atrial rate to the pacing rate, meaning you are not entraining the tachycardia. There is VA dissociation. The ventricular pacing is faster than the atrial rate during ventricular overdrive pacing, meaning you have not touched the atrium at all. This rule out AV AVRT. There cannot be a tachycardia, there cannot be AVRT where the V can be dissociated from the A. And if this response is present, meaning there is no atrial entrainment, it strongly favors the diagnosis of an atrial tachycardia. Response number 2, if the tachycardia terminates without conducting to the atrium, it rules out atrial tachycardia. Response number 3, which is a point of interest here, the atrial rate does accelerate to that of the pacing rate with 1-to-1 VA relationship. After the pacing is stopped, the tachycardia continues. So that gives you the opportunity to look for what is the response after termination of the ventricular overdrive pacing. Is it a VAV response or a VAAV response? As you can see here, this is the ventricular entrainment being done during the tachycardia, and the atrial rate has been accelerated to that of the ventricular pacing rate, meaning you have indeed entrained the tachycardia on faster ventricular pacing. Mind you, you are having a narrow QRS regular tachycardia with a 1-to-1 relationship, and you are doing ventricular pacing during the tachycardia. The atrial rate has accelerated to that of the ventricular pacing, so you know that you have entrained the tachycardia. You abruptly stop the pacing. This is the last paced beat that you see here. The ventricular spike here, followed by ventricular capture. This is the last VA conduction related to the ventricular pacing. Here is a V, and there is a A here. And what happens next is another A here. So this is what is called the VAAV response. This is very typical of an atrial tachycardia. There are two A's there after the ventricular pacing before the continuation of the tachycardia. This is quite typical of an atrial tachycardia. Now look at this in contrast. Here again, the patient has a narrow QRS tachycardia. You are doing a ventricular pacing at a rate faster than the tachycardia. The atrial rate does accelerate to that of the ventricular pacing rate. So you have indeed entrained the tachycardia. This is the last ventricular paced beat. So you have abruptly stopped the ventricular pacing. What happens here is, unlike the previous example, you have a V and then a, and then what happens is the next V itself comes. So this is a VAV response. This is quite typical of an AV nodal reentry or an AV reentry through an accessory pathway, unlike this example where you have two A's after the ventricular pacing is abruptly stopped. This is the VAV response because of an atrial tachycardia, and this is a VAV response, which is quite typical of an AV nodal reentry or an AV reentry. And these quantitative measures, let us not go through these quantitative measures in the interest of time. We'll do it in a subsequent occasion.
Yes.
I'll quickly touch upon what is this HIS refractory PVC, and we'll stop with that.
Yeah, I think so. The Parisian we don't need, I think.
Okay,
yeah.
So let us now talk about another interesting maneuver during a narrow QRS tachycardia is to deliver a timed ventricular extra stimulus at a time when the HIS bundle is refractory. If you give a ventricular extra stimulus when the HIS bundle is refractory, during a tachycardia, during a narrow QRS tachycardia with the one-to-one VA relationship, like for example, an atrial tachycardia or an AV reentry or an AV nodal reentry. If you deliver a ventricular extra stimulus when the His bundle is refractory, there is no way the ventricular impulse will be able to reach the atrium because the His bundle is refractory. But if there is a retrogradely conducting accessory pathway, this ventricular pacing impulse has an alternate route to engage the accessory pathway and to reach the atrium. So if there is an advancement of the next atrial activity after a His refractory PVC, it has to be an accessory pathway mediated tachycardia. If the His bundle is refractory, you are able to pre-excite the atrium, means there should be some other source of conduction from the ventricle to the atrium, and that is through an accessory pathway. In contrast, and then if there is an atrial advancement, the diagnosis is typical of an orthodromic AVRT mediated by an accessory pathway. In contrast, if you have an AV nodal reentry, there is no accessory pathway here. The tachycardia is progressing because a reentry between the slow pathway and the fast pathway in the vicinity of the AV node within the atrium. This tachycardia has nothing to do with the ventricle. Now you deliver a ventricular extra stimulus when the His bundle is refractory, let us say. There is no way the ventricular impulse will be able to reach the atrium because the His bundle is refractory and will not allow VA conduction. So the next atrial impulse during the tachycardia will be at the expected time, and it will not be pre-excited or it will not be advanced. So advancement of an atrium when a ventricular extra stimulus is delivered when His bundle is refractory is typical of an accessory pathway mediated ORT. If there is no atrial advancement during a His refractory PVC delivered during a tachycardia, it is in favor of an AV nodal reentry tachycardia, as you can see in this example. This ventricular extra stimulus is delivered when the His bundle is refractory. This is the His bundle here. This VPC is delivered. And if you see the next,
Natarajan, can you explain how that is falling in the His refractoriness?
the best way to know is you have to measure from the V to the His bundle before you do the pacing maneuver. From this interval to this interval, if you measure this interval to this interval, and you measure from this interval to this interval, in this example, you can even see the His bundle deflection here. You can see the His bundle deflection, and the ventricular extra stimulus is delivered at a time when the His bundle deflection came. So the His bundle has to be refractory. It should be around the time when the His bundle deflection happens. Then it is proof that you have indeed delivered a ventricular extra stimulus when the His bundle is refractory. But the point of interest here is the next atrial activity came at a time when it is expected to come. This AA interval is 320. This is also 320. This is also 320, meaning the atrial activity has not been advanced by this His bundle refractory PVC, which is a diagnosis, which makes the diagnosis of an AV NRT stronger. In contrast, if you see this will be the last slide that I will show. Here also you are delivering a His bundle refractory PVC. It's a PVC because the QRS is different in morphology as compared to the QRS before and after. Because you have captured the ventricle here, the QRS is different from this as well as this. It's something like a fusion beat. And that is delivered in time to the His bundle as measured from the V to the His bundle before and during the pace. But what is interesting here is when you delivered a His refractory PVC, look at the AA time. The AA time during the tachycardia was 270 milliseconds. Here, the atrium has been pulled forwards by a factor of nearly 25 milliseconds. So this atrial activity has been advanced or pre-excited by a ventricular extra stimulus delivered at a time when the His bundle is refractory, because there was an accessory pathway which was able to conduct the impulse from the ventricle to the atrium. Because the His bundle is refractory, there is another pathway, and that took the ventricular activity to the atrium, and that is why the atrium is advanced. So I spoke about a few points here. Number one, when the diagnosis is straightforward, you don't have to do maneuvers. When the diagnosis is in doubt, maneuvers are useful. In the short time that is possible, we discussed about two important maneuvers. That is ventricular entrainment at a rate faster than the tachycardia rate. Make sure that the atrial rate accelerates to the pacing rate. So you know that you have entrained. Abruptly stop the pacing and look at the return cycles. If there are two atrial activity before the next V, we call it VAAV response. That is quite typical of atrial tachycardia. In contrast, if there is a V followed by a single A and then the next V. We call it VAV response. And that is quite typical of AV nodal reentry or an AV reentry. Timed His bundle refractory PVC, if it advances the next A during a tachycardia, it is in favor of an accessory pathway. Thank you for your kind attention.
Dr. Natarajan, you would like to say about any bundle branch block occurring and then the tachy slows down being...
you can tell that, but I wanted to, maybe in the discussion you can add to that point, because I've already exceeded 15 minutes. I wanted to stop there.
Sure.
Maybe you can tell that.
Yeah. No, maybe if there's an example for that, as your residents keep telling us, your fellows keep presenting. So just to add to this thing, one of the usual hallmark that Yash is often, he shows us cases is when there's a bundle branch block which occurs during a tachycardia, and you see that tachycardia cycle length slows down. I mean, the tachycardia speed slows down, meaning the cycle length lengthens. So it would be very much confirmatory that there is a pathway mediating the tachycardia. Initially, it's narrow QRS. Due to whatever reason, there is a bundle branch block occurring, and then the QRS looks wider during the tachycardia as it continues. Then you would think that, but the speed, the rate at which now when it's wider is a bit slower, means that first there's a pathway, and the pathway is ipsilateral to the bundle which has blocked. So usually it's very apparent with the right bundle branch, with the left bundle branch block in a left lateral pathway, because that's pretty common. 40% of pathway mediated tachycardias are due to a far left lateral pathway. And then there's a left bundle branch block which occurs due to whatever reason, maybe rates, so on, aberrancy. So then because it's a macro reentrant circuit, so what maybe the mechanism can be understood later, but if you see that it's the speed slows down, then it would be very confirmatory that you're dealing with a pathway mediated tachy, which is ipsilateral to that side, so which is on the side of the bundle branch. Thank you.
Dr. Natarajan, just one question before we move to your presentations is that when the A's are following directly under the QRS, which is in our jargon often called as A on V tachycardia, is it always AVNRT or you could have a differential? You're on mute.
Whenever you have A on V or a V on A tachycardia, as Dr. Ashish says, when they are almost together, most often the diagnosis is a typical AV nodal reentry. It can of course be an anteroseptal accessory pathway mediated tachycardia. It can also be an atrial tachycardia with prolonged AV conduction. So this A is actually related to the next QRS complex. So we call it something like atrial tachycardia with first degree AV block. It may so happen that the P wave may be falling on the QRS complex, but actually the P is to the next QRS in terms of relationship. Whereas the AVRT and AVNRT, it is related to that particular QRS complex itself because they are due to retrograde conduction. We have a case to highlight this point, Dr. Ashish.
Sure. Praveen, you want to say something before we go?
I think Natarajan has explained in detail the basic teaching manuals, as well as Dr. Sharada has brought out that bundle branch block, and you have brought out the V on A tachycardia. Very rarely it can be a automatic tachycardia coming from that the slow pathway area. It can also be a on V tachycardia. I think in the interest of time, we'll go into the presentation. First, I will call Dr. Nischal to present this our first case.
Yes, Nischal, you can share. And
can you see my slide, sir?
not the slide yet.
Yeah.
Hello.
You can go to the presentation mode.
Okay. Good morning, everyone. I'm Dr. Nischal, a final year DM resident at Computer Institute of Medical Science. Is it full screen?
Yeah, perfect.
Okay. I'll discuss about a case involving mapping and ablation of anteroseptal accessory pathway, which was challenging exercise. It's about a 42-year-old male patient who came with complaints of recurrent episodes of palpitation since 3 years. Had structurally Yes, sir.
Go ahead.
Had a structurally normal heart. He was started on verapamil 120 mg, a sustainless OD, but he continued to have breakthrough palpitations. However, there was no ECG of the tachycardia available. So this was his baseline ECG. There was no pre-excitation, and his PR interval was about 146 milliseconds. He was taken up for EPS plus RFA. This is the fluoroscopic images in the LAO and the RAO, showing quadripolar catheter in the high right atrium, the quadripolar catheter in the RV, a quadripolar catheter in the Hess bundle, and a decapolar catheter in the coronary sinus. This is the baseline electrogram. The first three leads includes the electrocardiogram of lead 1, AVF, and V1. That is followed by the electrogram involving the high right atrium, the Hess bundle, and the CS. The CS here is labeled from distal to the proximal. So this CS 910 corresponds to the CS os, and this is followed by a RV electrogram. Here in the baseline, the AH interval is about 17 milliseconds. And the HV interval is about 47 milliseconds.
Themselves on mute, please.
And the others be muted, please.
Yeah, go ahead, Nishal.
Okay. Yeah, both the AH and the HV interval here at baseline is normal. The incremental atrial pacing at 300 milliseconds drivetrain. This resulted in the initiation of the tachycardia. The tachycardia initiated with the V, followed by the A, and the earliest A was in the Hess. And since the VA interval is very short, it could have been an AV-NRT or an AV-RT. Then at the drivetrain of 500 milliseconds, the incremental ventricular pacing, the 1:1 VA conduction occurred with the earliest A occurring in the Hess. This was suggestive of a concentric VA conduction, and kindly note the VA time in this drivetrain of 500 milliseconds. Next, at the drivetrain of 400 milliseconds, the VA conduction remained constant with 1:1 VA relationship. Even at drivetrain of 350 milliseconds, there was 1:1 VA conduction with the constant VA interval. And even at 300, it was constant VA interval. At 250 interval also, there was 1:1 relationship with a constant VA interval. This was suggestive of a concentric, non-decremental VA conduction. So this was helpful. This is actually helpful in differentiating between the concentric retrograde conduction that is occurring via AV node versus an anteroseptal axillary pathway. So in case of a retrograde conduction through a AV node, it would have been a decremental conduction. But since in case of an anteroseptal axillary pathway, it would be non-decremental. That is, with the decreasing cycle length, the time remains normal. And however, there was also initiation of tachycardia in this drivetrain pacing. Coming to the ventricular retrograde pacing protocol, at a drivetrain of 500 milliseconds, an extrasystole was given at 300 milliseconds. And this resulted in the VA conduction 1:1, similar to that during that previous we had shown. However, note the VA time interval in this at an extrasystole of 300 milliseconds. At an extrasystole of 280 milliseconds, there is again a constant VA interval. There is no decremental response here. The VA interval remains constant. Even at 270 milliseconds, the VA interval remains constant. Hence, we can see that during the ventricular retrograde, ventricular refractory pacing protocol, there is 1:1 VA conduction with the VA interval remaining constant over decreasing extrasystoles. So this is again suggestive of a retrograde conduction through an accessory pathway rather than via AV nodal pathway. And at an extrasystole of 270 milliseconds during the VRP protocol, there was no VA conduction. So this shows that the VA ERP was reached. Now, another maneuver to differentiate between the retrograde conduction occurring through the AV nodal pathway or a concealed anteroseptal axillary pathway is via parahesian pacing. In parahesian pacing, what we do is that we will pace the parahesian region initially with the low output, followed by a high output. in the low output pacing, both the only the ventricular myocardium is captured, whereas in the high output, both the myocardium and the His bundle is captured. So if at all during the low output, when only the myocardium is captured, if at all the retrograde conduction is through the AV node, then the conducting impulse has to go through the myocardium, through the Purkinje fibers, then the bundle branch, then the His, and then into the atrium. So the VA interval will be, stim to A interval will be longer. And once you pace with the high output, both the His and the myocardium will be captured. So that will result in a shorter stim to A interval. So short stim to A interval during high output and long stim to A interval during low output is suggested to offer retrograde conduction through a AV nodal pathway. However, if there is an accessory pathway, even at low output, when the His is not captured and only the myocardium is captured, the impulse can travel through the accessory pathway into the atrium, resulting in a short stim to A. So stim to A being same, that is short during both low output and high output, will suggest to offer retrograde conduction via accessory pathway. Here we can see that there was initially with the low output stim to A. So their impulse was generated here at the paraisian region. We can see a broad QRS complex, that is the low output, only the myocardium was captured. This resulted in a VA interval of about, stim to A interval of about 56 milliseconds. And during the high output, the stim to A interval remains same of about 50 milliseconds with an arrow QRS, because both the His and the myocardium was captured. This is suggestive that it is the retrograde conduction is through an anteroseptal accessory pathway and not through the nodal pathway. And coming to the atrial refractive protocol with a drive train of 500 milliseconds and an extrasystole given at 350 milliseconds, tachycardia was induced. This is suggestive that the mechanism is re-entry. And we can see that the earliest A occurred in the His, similar to that during the V pacing. And again, the tachycardia electrogram, where the tachycardia cycle length is about 320 milliseconds. We can see that there is 1:1 relationship between the V and the A, and the earliest A occurred in the His bundle. This is similar to that during the V pacing that we had seen. And this is the His refractory pacing that the sir was talking about. In His refractory pacing, exactly when the His is refractory, that is when we can see the His pacing electrogram here. The pacing potential is given here as exactly when the His is refractory. Then we will see the next advancing A. So if at all the retrograde conduction is through an accessory pathway, then even though the His is refractory, it will not matter. The impulse will travel through the accessory pathway to the atria. So the next atrial electrogram will occur slightly earlier to the previous. The previous cycle length, if you see, it is about 319. The next A to A interval is about 294. So here the A advancement has occurred. This is suggestive of a retrograde conduction through an accessory pathway. If at all there is no accessory pathway, so when the impulse was given at the His, when the His was refractory, the impulse was given at the RV, when the His was refractory, then the conduction would not occur through the AV node back to the atria, because the His is refractory at this time. So the atrial retrograde conduction to the atria would occur after a very long time. So this has not occurred here. So hence here, since there is A advancement, it is suggestive of an anteroseptal accessory pathway. Coming to the ablation of this pathway, for just an anatomy to show where the pathway could be in relationship to the aortic and aortic sinus. This aortic sinus is a pulmonary sinus. So we can see the non-coronary cusp here, and the His bundle is very close to the non-coronary cusp. And this is the inner LAO view, where the non-coronary cusp lies very close to the His bundle. So this is a fluoroscopic image where we have put an ablation catheter through the aorta with the ablation catheter tip lying in the non-coronary sinus. And why we chose to ablate via the non-coronary sinus is that the risk of AV block occurring while ablating through the non-coronary sinus is much lower. However, the ablation through the non-coronary sinus was not successful. Hence, we had decided to ablate through the anterior tricuspid annulus. So this is the ablation catheter seen in the anterior tricuspid annulus. And this is the tricuspid annulus. Through the anterior tricuspid annulus, we can ablate the pathway. However, the risk of AV block is higher while ablating from this side. So we can see the ablation catheter's potentials here. The V and the A is fused, and the A in the ablation catheter is occurring almost simultaneously when the his AA is occurring in the his bundle, indicating that the ablation catheter is at the axillary pathway. And the ablation was given, and the termination of the axillary pathway occurred within 3.5 seconds. And the ablation was continued for about 60 seconds. And RF delivery during the tachycardia resulted in the termination of the tachycardia. Soon after termination of the tachycardia, we can see the sinus beat where the A and the H interval is remaining normal. So this is very important.
Video. Your bandwidth is low. You can switch off your video.
Yes.
You have already exceeded your time. Be quick.
Yes.
Okay, carry on. It's okay.
Nishal, you can. No problem.
Nice.
Okay.
Go to the presentation.
We have to see the next sinus beat with the AH.
Nishal, you have to go to the presentation. Yeah, okay.
Yes, the where the AH interval is normal. So in the presence of a concealed anteroseptal axillary pathway mediated AVRT, the ablation should be done only during the tachycardia, and the ablation should not be done during V pacing, because during the V pacing we will not come to know whether we are ablating the AV node or the accessory pathway. So if at all we continue to ablate the AV node, the retrograde conduction will be happening through the accessory pathway, and we might end up completely destroying the AV node and resulting in CHB. Hence, it is very important that we have to ablate ablate only during the tachycardia, and soon after the axillary pathway gets ablated, the next sinus beat, AH interval, if it's normal, indicates that we have not damaged the AV node. And during the ablation, junctional rhythm occurred. We can see that initially the V and the A is separate, and here V and the A had fused, resulting in the junctional rhythm. And also we can see RBBB in the V1 electrocardiogram.
Sure, I think at this point we can have some discussion, isn't it?
Nishal, can you come to the conclusion slide?
Yes, sir. Take-home message is that the concealed anteroseptal pathway mediated orthodromic AVRT, it must be differentiated from AV-NRT. Para-His spacing is useful maneuver to differentiate between nodal versus retrograde pathway conduction. His refractory PVC advancing the next A favors AVRT, and non-decremental VA conduction pathway, it favors the non-decremental VA conduction, it favors pathway anteroseptal axillary pathway rather than the retrograde conduction through the AV node. And risk of AV block is high during radiofrequency ablation of the anteroseptal pathway. Hence, mapping and ablation through the non-coronary sinus minimizes this risk of AV block. Thank you.
Yeah. Can you just show the TCG once? Yeah, just out of interest, because we're talking to postgraduates in cardiology. Can you just show the sinus rhythm ECG? There's a subtly pointed in ARRHYTHMIA's algorithm, which Dr. No, in your.
No, this is post-ablation. She's asking for pre-ablation. First is.
Your slides, in your presentation slides, you've shown one of your second slides.
The base
yeah, first ECG. Yeah. Can you go to the presentation mode?
So like you can see that obviously the pre-excitation is very subtle here and we can't make too much comments, but you can see that in the lateral leads, definitely PR looks shorter. But in ARRHYTHMIA's algorithm, which Dr. Sam Asirvadan often points out, if you have a small R in V1, that you should keep your mind open to a septal pathway. So just wanted to bring it out. Obviously, these would be more clinching if it was more pre-excited, but even with this, you would have in your back of your mind that such a short PR looking like there's a definite slur on the initial part of the QRS, if you see it closely. And with that thing, if you have a very small R in V1, that would point towards having a septal pathway. So either anteroseptal or posteroseptal, depending on the inferior lead contour, but that's one of the things I wanted to say.
Good remarks.
Yeah, and tachycardia, yeah, ablation either during tachycardia or when you terminate, maybe you should have an A pacing going on so that you ensure that the AH doesn't prolong because junctionals often can occur. So if you ablate during junctionals, you would miss having VA block due to native conduction being, maybe perhaps not for this population. Ashish can.
Nishchal, does the mode of induction definitely tell you what kind of supraventricular tachycardia it is, whether you are inducing from the atrium or the ventricle?
Sir, when during the extrasystole delivered through the ventricle, if the tachycardia get induced, so re-entry is the usual cause of the tachycardia.
Yeah, AV reentrant tachycardia is more likely. AV NRTs with great difficulty will be induced from the ventricle because there is a delay from the RV apex if you're stimulating there till the AV node reentry circuit. So you don't easily induce a AV NRT by ventricular extras, can be easily induced by atrial, whereas AV RT can be both ways. And while atrial tachycardias will obviously be easily inducible by atrial stimulation, they can also be induced by ventricular stimulation as long as the VA conduction is there. So it is not absolute from where you induce that it will help you to distinguish, but some clues.
Yeah, but the case also pointed out very nicely for the cardiology fellows that non-decremental conduction while you're doing the V-pacing is very nicely pointed out that AV node decrements, whereas pathways do not decrement. They either conduct or don't conduct. So that's very nicely illustrated.
Yeah. Let's move to the next.
Yeah, I think we'll go to the next case by Dr. Anugrah.
Yash wants to speak, but is
Yash is muted, I think.
मैं अपना म्यूट करूँ क्या फुल आउट स्पीकर
Yash.
Audible?
Yeah, you are audible. You can go to the presentation mode. Yash, you are muted.
Sir, are my slides visible?
Yeah, you can go to the presentation mode.
Dr. Yash was trying to say something.
Yeah, he was muted. Still, you could hear something.
Anugrah, just wait for a minute. We want to hear what Dr. Yash
I'll
wants.
just see if I can make him.
Yeah, we'll wait for. Shall we wait, Ashish? Still.
Yeah, I'll just see if I can put him on.
Good to listen to his comment.
Yeah, yeah.
We could also try Dr. Natarajan, not for this fellows, but maybe going superior approach from jugular
Amita,
approach.
can you
for
put
ablation.
Yash on? Can you unmute him?
Actually, the network is very low, so he's exited.
Yeah.
He's not in a meeting right now.
Okay.
He has to join again. The network is very low from his side.
Okay. Let's go on with Anugrah.
Dr. Sarada made a good point that you can also
we missed it. Yeah.
anteroseptal axillary pathway from the jugular route also.
Yeah.
Good morning, all. I'm Dr. Anugrah, final year DM resident, and today I'll be presenting a case of recurrent PSVT with failed ablation elsewhere, having recurrent breakthrough episodes in spite of it. My case is a 57-year-old female, a hypertensive dyslipidemic, with history of documented multiple episodes of PSVT since 2017 and was initiated on drug therapy. She was evaluated elsewhere in 2019, where an angio reported normal, EPS done, showed a typical AVNRT, and slow pathway modification was attempted in another institution in 2019, but the tachycardia continued to be inducible and the procedure was unsuccessful. She continued to have breakthrough episodes while on drug therapy. Her baseline ECG, sinus rhythm 70 per minute with normal PR and QRS intervals and no evidence of pre-excitation. Her echo was a structurally normal heart with good LV function. The EP study. The basal study in sinus rhythm showed no evidence of pre-excitation with a sinus cycle length of 945 milliseconds.
If I just interrupt you here, an AVNRT, a failed ablation comes to you again with SVT. What are the things that are moving in your mind?
Sir, possibly that we're not dealing with a typical AVNRT, maybe an atypical variant, or it could be a focal atrial tachycardia causing the SVT.
Yeah, sometimes the slow pathway could be at a different site than the usual slow pathway.
Left atrial.
Wrong diagnosis or wrong site of, or some alternative site of ablation is what broadly you can think of. Okay, go ahead.
So the basal study showed a cycle length of 945 milliseconds.
Hi, Ash.
An AH interval of 81 milliseconds, an HV interval of 39 milliseconds. The retrograde study. Incremental ventricular pacing was done with RV pacing at 660 milliseconds, and it showed a concentric VA conduction with a VA BCL of 550 milliseconds. On single extra stimulus protocol, it showed decremental VA conduction, and this was suggestive of conduction through the node. The anterograde study. The incremental atrial pacing protocol at 500 milliseconds showed an AH interval of 129 milliseconds. As the cycle length was reduced to 400 milliseconds, the AH interval became 198 milliseconds. This was an indicator towards our diagnosis. Now, IAP protocol showed atrial cycle length progressively shortening until the atria did not conduct to a ventricle with an AV BCL of 370 milliseconds. Using a single atrial extrastimulus protocol, it induced a narrow complex regular tachycardia without a preceding AH jump. This was indicative of a reentrant mechanism. The tachycardia study. There is concentric atrial activation sequence during the tachycardia with a tachycardia cycle length of 400 milliseconds, an AH interval of 220 milliseconds. The HA interval was more than the AH interval, with the earliest A in the HIS. Thereby, then his refractory PVC was done, which showed no atrial advancement, which ruled out an accessory pathway. Triple ventricular extrastimulus protocol was done, and it did not terminate the tachycardia. When V pacing was done at a faster rate to the tachycardia, there was lack of atrial entrainment, and V was dissociated from the A. So there was lack of entrainment of A during V pacing. So AVRT is ruled out as V could be dissociated from the A. A diagnosis of a micro-reentrant atrial tachycardia from the anterior triangle of Koch versus AVNRT was entertained. With a remote possibility of AVNRT, mapping of the triangle of Koch was done with a large curve 4 mm catheter. This is the fluoro image of the mapping. At the posterior triangle of Koch, ablation was given at 45 watts for 90 seconds, and it showed a sustained junctional rhythm. However, post-ablation, the tachycardia was still reinducible on single atrial extrastimulus protocol. It is noteworthy that there is no AH jump, and there are 2 A's on tachycardia initiation. Mapping of the anterior tricuspid region at 1 and 2 o'clock position was done. This revealed a local A during the tachycardia and time with A in the HIS. RF delivery at low watts at this site did not terminate the tachycardia. Hence, it was decided to map the non-coronary aortic cusp using an irrigated RF catheter. During tachycardia, the local A in the non-coronary cusp was in time with that of the HIS. RF the delivery began 30 watts, and after 2.6 seconds of the tachycardia abruptly terminated, and RF delivery was continued for a total of 60 seconds. This is the floor image of the successful RFA site in AP view, RAO view, and LAO view. Post-ablation. The tachycardia was not induced on double atrial extrastimulus protocol. Tachycardia was not induced even after giving isoprenaline. And after repeating the protocol after 30 minutes, it was not induced. So the final impression was an anterior triangle of cock, focal micro-reentrant atrial tachycardia, and successful RFA was done through a retroaortic route at the non-coronary cusp. To summarize the subtle differences between the AV and RT and atrial tachycardia, induction of the tachycardia on atrial extrastimulus protocol favors an AV and RT. It is unlikely in atrial tachycardias unless the mechanism is a micro-reentrant. Usually, AV and RTs have an absence of VA conduction, and dual AV nodal physiology favors an AV and RT. Entrainment of the tachycardia on V pacing shows a VAV response in AV and RT and a VAV response in an atrial tachycardia. Termination of the tachycardia on V pacing favors an AV and RT. And the AH interval during A pacing at tachycardia cycle length more than the AH during the tachycardia favors an AV and RT. So my take-home messages are that what initially was treated as a typical AV and RT was in fact not so typical. The tachycardia was reinducible despite ablating the slow pathway region. There were pointers to the diagnosis of an atrial tachycardia, which were no AH jump, AH during. Hello. So the pointers were there was no AH jump. The AH during pacing at tachycardia cycle length was nearly identical to that during the tachycardia. There was lack of atrial entrainment during V pacing and non-termination of the tachycardia on V pacing. Considering the possibility of a focal micro-reentrant atrial tachycardia from the anterior triangle of cock, ablation was attempted from the NCC. This led to a successful ablation. Thank you.
Thanks, Anugrah, for that good presentation. Natarajan, there was a question of what is AVBCL. Can you explain?
Anugrah, you can show your own slide that you can reshare your screen, and one question came in the chat box.
AVBCL, they want to know.
AVBCL.
AV block cycle length.
So are my slides visible?
Yeah. Here the pacing has been stopped. So I wish we had a slide where the pacing is continued and there is demonstration of AV block. You can see, at least in this example, you can see in the top, you have a longer RR interval on the first, between the first two QRS complexes, the RR interval is longer. Did you see that? Yeah. And the pacing, the atrium is getting captured at a faster rate. That itself is a rough indication that you have reached AV block. If there's a one-to-one relationship between atrial pacing and conducted beat to the ventricle, you will have the same RR interval as that of the PP interval.
And there one more question is the local A must be earlier than his in NCC.
It was earlier.
Earlier. Yeah.
Earlier.
Can you show that slide?
It was earlier.
I don't know whether we have that picture.
The successful ablation you can show. Not this one, ablation. Where it terminated, you show that particular thing.
Yeah.
This is actually this is just to show that 2.6 seconds termination, but we have measured it. It was earlier by about 5 milliseconds.
And the third question is, how is mapping done with the ablation catheter?
So effectively, what is meant by activation mapping? Dr. Natarajan, if you can.
Pardon?
What is meant by activation mapping? When you
activation mapping means the local signal. See, you have to draw the distinction between electrocardiogram and electrogram. Electrocardiogram is recording of the electrical activity of the heart from the surface of the body. You have the typical 12-lead ECG. What is recorded from the internal signals, whether it is right atrium, whether it is his bundle, whether there is coronary sinus, you should use the word electrogram, not electrocardiogram. So in the map catheter, or rather in the ablation catheter, which is used for mapping, the local signal timing is compared to that of other locations. For example, if it is a ventricular tachycardia, you can see the local ventricular electrogram, how early it is in comparison to the QRS complex in the surface ECG. Likewise, in this example, you should measure the local atrial electrogram from the non-coronary cusp and see how early it is from the other earliest location. We said in the beginning that the earliest was in the his bundle. So in comparison to the his bundle atrial electrogram, how early is the local atrial electrogram as recorded from the mapping catheter in the non-coronary sinus. In this particular case, the local atrial electrogram from the NCC was 5 milliseconds earlier than the local electrogram in the HIS bundle, which we thought was the earliest intracardiac signal otherwise. I hope I have answered your question.
Right. So there is something called as unipolar mapping and there is entrainment mapping. So these are different ways, this space mapping, how you try to reach the culprit site that is responsible for the maintenance of the arrhythmia, and then you decide, make your candidate ablation site and see if it works there. So that is general how ablation is done after mapping. Another thing is, can stimulation protocol help you, Dr. Natarajan, to distinguish between the mechanisms, whether it is a triggered activity, automaticity, or a re-entry? Short answer. Yeah.
Automaticity is usually by rapid pacing from the chamber of interest. For example, if you have an atrial tachycardia, you pace the atrium faster from any location, either right atrium or proximal coronary sinus. Burst pacing from the chamber usually induces an automaticity-based tachycardia. Oftentimes, you may have to repeat the stimulation protocols on isoprenyl. So when there is catecholaminergic state and on rapid pacing, or it may even come spontaneously. That is very typical of an automaticity-based tachycardia. In contrast, a re-entry tachycardia is usually by an extra stimulus protocol, a single extra stimulus or a double extra stimulus protocol. Induction is very typical of a re-entry.
Yes. Sure.
Can we go to the next case?
Yeah, just to bring to note, just to bring up this, that because one of the closed differentials is an atypical AV NRT, as was discussed earlier. Usually, the earliest atrial activation in that would have been expected to be in the PCS location, but here you see that the HIS location is more anterior, definitely more superior anterior, and coronary sinus is posterior inferior, and in a atypical AVNRT, the earliest retrograde A would be around the CS proximal, which is a posterior location of the triangle of Cox. So the fact that this is away is one important indicator that this is not a usually atypical AV.
Yeah, just to reiterate for the postgraduate, atypical is fast, slow. And that's why Dr. Sharda says that the retrograde slow pathway activation will be close to the coronary sinus. Okay, let's move to the next one by Vijay.
Slides visible?
Yeah. You can go to the presentation mode.
Presentation.
Yeah, okay.
Okay. Good morning, everybody. I am Dr. Dikchanjan, final year DM resident in Amrita Institute. Today, we'll be discussing a very common AV NRT, but the ablation of which is always very easy, but this time it wasn't. So this is a case of 43-year-old male with no known comorbidities. He presented to the hospital with complaints of multiple episodes of paroxysmal palpitation since 25 years of age. There was history of termination with IV medications, likely to be adenosine, but we do not have any documented evidence of the tachycardia ECG. He was advised CAG elsewhere in view of ECG changes and a positive troponin T after the SVT episode. The angiogram elsewhere showed mild CAD and the echo showed structurally normal heart. He was started on tablet caleptin sustained release, but had breakthrough palpitations even on that, and hence he was taken up for an EP study. So this baseline ECG, we can see a sinus rhythm, a heart rate of 74 per minute, and no pre-excitation is present. In this fluoroscopic image, we can see 3 quadrupolar electrodes, one in the RA, second in the RV, and third in the HIS bundle, and a fourth decapolar is seen in the coronary sinus. So in the basal study, the patient was in sinus rhythm at the onset of the study with a sinus cycle length of 720 milliseconds, an AH interval of 118 milliseconds, and an HV interval of 39 milliseconds with no excitation seen. The ventricular pacing was done and it showed a concentric VA conduction with the earliest A seen in HIS and in the proximal coronary sinus. Now, the ventricular extrastimulus protocol showed an S1 drivetrain of 650 milliseconds, and an extrastimulus was delivered at 530 milliseconds, which showed a concentric VA conduction. Now, the ventricular extrastimulus protocol with the drivetrain of 650 milliseconds and the extrastimulus was delivered at 520 milliseconds showed a VA ERP was reached, as we cannot say any A. So now the HRA pacing was done at 350 milliseconds. There we can see an AV crossover, that this is the A and this is the V. So this denotes a PR interval which is greater than the normal RR interval. Hence, it denotes a possible slow pathway conduction. Now, HRA single extrastimulus protocol showed that the AV ERP at a drivetrain of 500 milliseconds was reached at 270 milliseconds. Atrial double extrastimulus protocol from a proximal coronary sinus showed a significant AV jump and no AV nodal echo beat was seen. So now we are here with that there was a dual AV node physiology as was seen in AV crossover with PR interval more than the RR interval and a significant AH jump. There was concentric VA conduction. However, the tachycardia could not be induced on single as well as double atrial extrastimulus protocols from two locations, that is the high right atrium and the proximal coronary sinus. Therefore, the protocols were then repeated on isoprenaline. So on isoprenaline, atrial extrastimulus protocol from high right atrium, A on B tachycardia was induced, as we can see here, which is typical of AV NRT. So the radiofrequency delivery at the posterior sites did not result in junctional acceleration. Therefore, we had to go into the middle sites, that is the M1, M2 site, and there was junctional acceleration. But we also had a problem of catheter instability here. So during the slow pathway ablation, we often see accelerated junctional rhythm as is seen here. The important aspect is to concentrate on 1:1 VA conduction during junctional acceleration, which we can observe here. So while ablating the slow pathway during junctional acceleration, radiofrequency delivery has to be turned off, as can be seen from this vertical line. It has to be turned off immediately when there is no VA conduction. Here we can see the V but not the A. The radiofrequency delivery was stopped at 35 seconds at the M1, M2 site. So post first radiofrequency pulse for 35 seconds, single atrial extrastimulus protocol showed an AH jump. Here we can see the AH jump with single AV nodal echo beat. However, tachycardia was re-induced on double atrial extrastimulus protocol on isoprenaline. This is the tachycardia ECG. Therefore, because of catheter instability, we used an SR0 long sheath to stabilize the position of the catheter at M1, M2 site. This is the long sheath. So points to be noted are junctional acceleration is seen. However, there is isorhythmic AV dissociation between the sinus and the junctional. We do not know if AV nodal injury has happened or not. So therefore, it is unsafe to continue with the ablation. So what's next? The radiofrequency ablation, the radiofrequency was again started on confirming the junctional acceleration. So the atrium was paced faster and the radiofrequency delivery was continued, ensuring 1:1 AV conduction without AH prolongation. Radiofrequency delivery was continued during A pacing. 1:1 AV conduction was seen with a normal AH interval. Post radiofrequency ablation on double atrial extrastimulus protocol, as is seen here, AH jump with single AV nodal echo beat was seen. Tachycardia could not be re-induced. Post radiofrequency ablation on double atrial extrastimulus protocol, AV-ERP was achieved. Post radiofrequency ablation, AV block at 360 milliseconds was seen. So the take-home message from my presentation will be, AV-NRT is the commonest form of supraventricular tachycardia. It is a benign arrhythmia, hence AV block needing permanent pacing must be avoided. The junctional acceleration during radiofrequency delivery is the key to successful slow pathway ablation or modification. However, we must ensure 1:1 VA conduction during junctional acceleration. If there is isorhythmic AV dissociation during junctional acceleration, it is unsafe to continue radiofrequency delivery. Radiofrequency delivery during atrial pacing helps in this scenario. And a long sheath to stabilize the radiofrequency catheter at crucial sites is a useful option. Thank you.
Very nice, Diksha.
Dr. Sharada, I think these are the last 2 points where what Dr. Sharada told last, that sometime during junctional acceleration, it is better to pace the atrium so that we don't miss the age prolongation. Ashish, could you get Dr. Yash?
Only one
minute.
point I want to make is, Dikshan during his presentation told that AV-NRT is the easiest thing to ablate. That is not actually true. AV-NRT can sometimes be very difficult, and you have the unique problem of avoiding CHP, which makes AV-NRT the commonest arrhythmia, but not so easy to ablate. So you have to be very, very careful, as you correctly said. So one small correction, you said is the easiest to ablate. It's not so easy.
Shant, a couple of things. Any supraventricular tachycardia is associated with coronary artery disease?
I wanted to provoke you by putting that particular statement. Angiogram was done elsewhere. Troponin was positive. It is done. Even 25-year-old patients also have an angiogram, and then they come to the EP center.
Yes, so what we call as PSVT is the AV-NRTs and AVRTs, obviously not. But if you have an atrial tachycardia, it could be resulting from a structural heart disease, which could be previous infarction. In that sense, it could be a coronary artery disease present in a patient with SVT, but not with AV-NRTs and AVRTs. Does the location of where you stimulate matter to the induction of tachycardia? Which tachycardia matter? Dikshan? Or even Nishal can take, or anybody. Does the site of stimulation matter to the induction of tachycardia, or when does it matter?
Obviously, the closer it is to the tachycardia circuit, you would be able to get into the circuit well. So always you would expect mostly that to be in the posterior location. So pacing from CS, when HRA stimulation doesn't induce tachy, you would try to do that. So I see in the chat box there's some question about when we pace atrium, how can we see junctional beats? We do not see junctional beats. We are actually overdrive suppressing them. So you're allowing a 1:1 because you're pacing at a faster rate than a slow junctional, and so we ensure that there is a AV conduction going on. Just to summarize again, because again, cardiology fellows should know that AV-NRT is more likely when you're seeing a more aged population. So beyond 40 years, more common in females. And frog sign. What is frog sign is that the A and B are simultaneous. So the patient can complain by himself that he can feel neck pulsation. So 40 female and frog sign is easy to remember, which obviously in this case, this was a male patient, but in general, more pointers towards AV-NRT when you have more aged person with the typical history of frog sign. Why? Because the VA conduction is through fast pathway, which is so fast that it's nearly simultaneous. So that's why we see the VAs lined up. In EP study, when you have the echo beat also, you see that you have V, or as they were saying, A on V or V on E, they're simultaneous. Yeah, so that leads clinically, I want the residents or the fellows to know that that can be, if somebody comes with saying that they can feel neck pulsations when the age is more than 40, I think that perhaps we're dealing with an AV in that.
Yeah, great comments, Dr. Sharma. So we want to move, Praveen.
Yeah, I think we will go to the next device case. I will call Dr. Bhagirath also to take part. We'll go to
good morning. Good morning, everybody, once again. So we have the next segment this morning, that is the CID segment. We have two case presentations here. The first one is Dr. Tanmay Kulkarni. This is syncope in a patient with functional dual chamber pacemaker. So over to you, Dr. Tanmay.
Thank you, sir. Am I audible?
Yeah.
Yes, audible. Slide C.
Good morning, everybody. I am Dr. Tanmay Sandeep Kulkarni. I am final year DM resident in Amrita Hospital. I am presenting a case of syncope in a patient with functioning DDD pacemaker, a diagnostic challenge. 64-year-old man, history of complete heart block, underwent permanent pacemaker implantation, DDDR, in October 2010. He had pocket infection in 2017. Patient was unwilling for lead extraction, so only PG explantation was done. RVOT lead was abandoned and atrial lead was partially explanted. It was followed by re-implantation of the new PG plus new leads in May 2017. He was doing well on regular pacemaker follow-up. This is the X-ray after PG change. This the new PG leads, one present lead, atrial lead, abandoned RVOT and partially explanted atrial lead. 2 years later, he presented with one episode of transient loss of consciousness associated with clonic jerks, post-recovery slurred speech, which recovered in 30 minutes. He was admitted for evaluation. Device interrogation was performed, which showed ideal parameters. Fluoroscopy showed no lead fracture or insulation issues. He was admitted a month later, again with 5 to 6 episodes of syncope. That time, device interrogation was performed, which revealed adequate battery voltage, ideal lead parameters, and excellent capture threshold. RV sensitivity settings were changed to avoid oversensing with consideration of close proximity of the abandoned RVOT lead with the present RVOT lead and to avoid lead-to-lead interaction. Routine biochemical parameters were normal and CBC was normal. To have special note that all the episodes of syncope occurred in the sitting posture, either reading newspaper or watching a TV, and there were no warning signs at all, which was very much suggestive of arrhythmic syncope. 24-hour Holter was performed, 100% ASVP rhythm, very few APCs or VPCs. Video EEG, no epileptiform activities, while echo is...
Can I make a comment?
Yeah.
So usually, if the lead is inadvertently in the left ventricle, you can have stroke and slurring of speech. So that also should be considered.
Okay.
Go ahead.
Yeah. So he was discharged, but again, story continued. He had another episode of syncope, and this time it was preceded by chest discomfort, typical of angina. Angiogram was performed, which revealed single vessel disease, proximal LAD 90% tight lesion. So we thought that we might have a diagnosis. So this might be the reason. So he underwent PTCA with stent to LAD. This is the cine image, proximal LAD tight lesion, iliocranial. This was the dilatation, stenting done, and good results, excellent results. He was discharged, but he got readmitted with 4 episodes of syncope 2 weeks later. ECG was ASVP. Device manipulation was performed this time in the pocket with simultaneous monitor of the ECG, which was normal. There was no loss of capture with isometric chest muscle exercises. The interrogated parameters were sent to the company also, and they reverted back that there is no problem, there is no cause identified. This was the ECG taken that time, ASVP. So we went ahead with 7-day prolonged ECG monitoring, suspecting this is cardiac issue. So this was the graph which showed the pacemaker output failure. There is no activity. There is ventricular standstill, which was recorded. This was evening 6 o'clock when he was doing a routine activity. We can see multiple P waves, which are not conducted. There's a complete heart block. Some escape rhythm appeared later on. So we got the diagnosis in this case that there is ventricular standstill, 15 seconds almost. But patient made it to the hospital and we immediately took him for the pacemaker device change along with new ventricular lead and old atrial lead in February 2020. So at the time of device change, ventricular lead impedance and capture threshold were normal. So however, new lead was used considering the rare possibility of intermittent lead malfunction. And as there was a fatal bradycardia, fatal asystole, so we did not want to take any risk on this patient now. So we changed the both. There are multiple leads now, 2 abandoned, and patient was unwilling for the extraction, so they were left there. There was no subsequent syncope during the next 26 months of follow. This was after the recent new PG change. So this was a real frustrating chase for the cause of syncope, and this is the follow-up ECG. To summarize, pacemaker failure can be categorized under pacing failure and sensing failure. Problem related to pacings are either output failure or failure to capture. So these pacing problems could lead to life-threatening bradyarrhythmias as well as asystole in pacemaker-dependent patients, as happened in this case. And problem related to sensing, particular to this case, might be related to oversensing. Not this case, but in such scenario, oversensing might cause such problem. So to define output failure, it is defined as the inability of pacemaker to generate an impulse resulting in heart rate which is lower than programmed lower rate limit. Causes are lead fracture, generator failure, which might be due to battery depletion, or extreme rarely device circuit failure, which was the working diagnosis for this case. Inhibition of pacing due to oversensing and crosstalk is also one of the cause for output failure. While the failure to capture defined as inability of pacing impulse to produce and evoke potential. Causes are lead dislodgement, elevated threshold due to fibrosis, exit block at the site, while metabolic causes to remember are acidosis or hyperkalemia. Thank you for this opportunity.
Thank you, Dr. Tanmay. I think Dr. Sharda.
No, I was very intrigued that he said that episodes were on sitting. So I was just wondering what would happen sitting for the lead to be so malfunctioning. What were the postulates in the clinician's mind?
So, the final working diagnosis was pacemaker failure.
Yes.
We didn't want to take any chances, so we changed the lead because there was no evidence whatsoever of lead malfunction in this case. This was a clear case of abrupt pacing failure. There are no spikes at all. And that kind of an abrupt pacing failure for 15 seconds is very unlikely to be over-sensing related as well. That's why we thought it could be a rare case of pacemaker circuit failure.
I think a very beautiful case. A lot of points for discussion here. I don't know how much time we have, Dr. Ashish, but of course, device interrogation from the conventional fluoro to micro dislodgement of the lead as well as lead fracture. These are things that you need to look into apart from the programming parameters. As you rightly pointed out, an extended Holter is often very, very useful to pick up events that don't show up within the 24-hour interval. A tilt table test. We had a patient where there was vasodepressor syncope, and we almost completely missed it till we picked it up by doing a tilt table test. We also need to look at the medications that the patient's on, whether there's some other reason for hypotension. Of course, here it's clearly there is no capture as seen on the Holter. And of course, coronary artery disease. That was a good pickup, proximal LAD lesion that could have even ended up fatally. So number of points for discussion. Over to the house to take this further. Comments from Dr. Natarajan and team, Dr. Sharda, Dr.
Yeah, again, not pertaining to
Ashish.
this case, but I just want the fellows to know that when you have brady patient with conduction system abnormality, if they have syncope, please realize that 40 to 50% are not just related. Here, the patient has a pacemaker, but suppose you're evaluating a patient, or even in such a patient, so you have syncope as a presentation and you have a brady as an underlying possibility. We'll always think brady to be the cause. No, especially conduction system abnormality, very, very commonly, almost 40 to 50% according to Josephson is due to tachy or VT, which can cause such a thing, which is like, perhaps we don't encounter like that, but it's always good to keep in, just to add on to their knowledge.
As you said, oversensing is far more common than the pacemaker output failure. What maneuvers do you do to elicit the oversensing to demonstrate the lead integrity issue?
He did mention during his presentation that isometric chest wall exercise, device manipulation, deep breathing, all that should be done with simultaneous monitoring. That's a very important point which Dr. Sarada brought out. Think of, and Dr. Bhagirath also, think of possibilities like the tachycardia. Tachycardia is extremely possible, especially if a patient has LV dysfunction. The patient has, and the patient obviously has a conduction system disorder. That's why the patient is having a pacemaker. So tachycardia has to be kept in mind. Coronary artery disease, vasodepressor syncope. That's why I wanted him to stress the fact that this happened not during any peculiar situations. We were sitting and casually watching TV. That time you don't expect a vasovagal kind of a syncope. That's what we thought.
So abducting the arm, apart from isometric exercises, abducting the arm to sort of separate fractured segments. Yeah.
Sure. Okay. To the last one.
I think we have the last presentation. Lead extraction. When there are cost constraints, think differently. So let's see Dr. Vijay Nagappa with thinking out of the box. What do you have for us?
So good morning. I'm Dr. Vijay, final year DM resident from Amrita Hospital. So we'll be discussing about the pocket site infection, that lead extraction when there are cost constraint. Think differently. So discussing patient 56-year-old male patient who is a diabetic, dyslipidemic, has a post-COVID infection in April, was home quarantine for COVID infection. She underwent a permanent pacemaker implantation in 2010 elsewhere for a complete heart block. During that time, angiogram showed as minor CAD. Then during follow-up, he underwent pacemaker pulse generator PG change in December last year for ERI. So during the follow-up year, he noticed that there was a mild delayed healing at the middle end of the wound. So he was advised regular dressing and he was started oral antibiotic. So on the next month, he came to the ER with a pocket site infection and complete extrusion of the device. As you can see the complete extrusion of the device. So from that side, there's a cultures. Pus culture was sent, showed coagulous negative staphylococcus sensitive to antibiotic. So it was started appropriate parental antibiotic. The present standard of care is complete extraction of the lead for elimination of the future risk of delayed infection. So he was conscious for the lead extraction. However, he was unwilling due to cost constraint. But after convincing, he underwent the PG explantation. So the first scene is showing that the pacemaker in situ with the lead in situ. Second one, this scene showing a patient temporary pacemaker and with the traction giving from the pocket side. In spite of giving consistent maximum traction, that lead was not unable to dislodge or from the RV side. So what we did is, so we used RF catheter. RF ablation catheter. So we usually first put the RF catheter across the lead. Then we try to dislodge or release the lead from the RV side. After that, in spite of that, it was not able to give traction, not able to come. So what we used is snare. By using the snare, so that easily came out from the femoral root. This one a post procedure patient he was on, since he was on pacemaker dependent, he was on TPI. And after adequate antibiotic, IV antibiotic duration and on TPI, he underwent pacemaker reimplantation next month. So this was the final scene showing that pacemaker, new pacemaker site and the lead in situ. This is ECG showing V-pacing. So in the Danish registry of pacemaker implantation between 1982 and 2007, the incidence of infection was 4.82 per 1,000 device years after primary implantation. and 12.12 by 1000 device years after replacement. Device-related infection incidence during device lifetime was 1.19% for pacemaker, 1.91% for the ICD, 2.18% for CRTP, and 3.35 for the CRTD. Infection rate was lowest during the initial implantation, and during the reimplantation revision process, it was raised to 1.5 to 3. There's some risk factor for the infection as the end-stage renal disease, congestive heart failure, diabetes, COPD, long-term steroids, some hematoma. All those are common risk factor for the device infection. So a common infection, you can say incisional erythema, pocket site infection, systemic infection. In our case, a patient with high-risk intracardiac infection with culture positive, what the guidelines is a systemic extraction, system extraction plus antibiotic. So the guideline is in patient with definite implantable electronic device infection, complete device removal is recommended, including abandoned leads, epicardial leads, and lead fragments. After diagnosis of pacemaker device infection, the device removal process should be performed without unnecessary delay. So ideally within 3 days. So recommended technique for device removal is percutaneous or transvenous extraction technique, or if epicardial leads required, surgical removal. So take home message from a case is pacemaker pocket infection is most undesirable complication during follow-up. Fortunately, it is uncommon. When there is a pocket infection, the best approach is to remove the entire system, including leads. In chronic leads, lead extraction tools are essential. However, they add to cost. When there are cost constraints, inexpensive options like snaring from the femoral axis are to be considered. Releasing the ventricle end of the lead using deflectable ablation catheter without adding cost was a useful out-of-box thinking in this case. Thank you.
Thank you. Thank you, Dr. Vijay. That was an excellent idea. I think that saved the day for you. A couple of observations here. One is that the lead was still unscrewed. The screw was still open, and probably that's why you could not easily get that out. And with that, snaring it down, there is a risk of a tamponade, or there is a risk of laceration of the blood vessel. So lucky you got away, but I think this is a dangerous situation which is likely to end up in a serious problem. The second thing is we noticed that you've reimplanted the pacemaker on the same side. Just wanted your comments. I think it's always a rule to use a new pacemaker, new lead, and on the contralateral side. So
it was initially, sir, it was on the right side. We reimplanted on the left side.
Your fluoro image suggests the same side.
No,
sir.
No, it was on the opposite side.
Show the current pacemaker.
This is
the current pacemaker.
Yes, present
the new one. Show the new one image. Yeah, it is on the other side, other one. Yeah,
left side.
It's on the left side.
All right, you put it, yeah. So because it's always a protocol to put it on the other side.
Yes, absolutely.
So what is the role of transesophageal echo prior to undertaking this procedure?
Maybe you're talking with reference to lead endocarditis?
Yes. And intraprocedure.
And thrombosis.
Yeah, one has to rule out the infective endocarditis on the lead, and transesophageal echo resolves it better than transthoracic. So almost everybody should get that.
Because then the antibiotic course would be definitely longer. It will be like
Yes.
4 to 6 weeks and not just 2 weeks that we give.
And the size of vegetation would also decide what method you use. Sometimes FDG PET is used to decide how much is the infective part.
Dr. Ashish, how good is PET for lead endocarditis? Pickup.
I have seen on lead, it is more for a systemic when you don't know the source also, but resolution obviously is lesser, but it helps because the lead, the mass on the lead can be a vegetation as well as a thrombus. So that resolution can be a slightly different when you do FDG PET. If there's uptake on the lead, then it's obviously infection.
To answer to what Dr. Bhagirath was mentioning, some of the historic screw-in leads, which have been there for 15 years, oftentimes we have difficulty in unscrewing it. If it is a recently implanted lead or 2 years or so, it might come. Some of these leads which have been there for nearly more than 10 years.
Yes, the screw mechanism doesn't work.
And fortunately, even if the screw doesn't come inside, screw-in leads are the easier ones to extract as compared to tined leads, because the fibrotic reaction is far more denser in a tined lead than a screw-in lead. And oftentimes we get away without rupture or anything. Having said that, extraction itself is a risky endeavor, but it is worth taking, because a lot of patients where we have left lead fragments inside come back with delayed infections years later. I recently had a patient where we had trimmed off the lead because it wouldn't come. She came 14 years later with a sinus on the explanted site. The new pacemaker, which was done 10 years back, was perfectly all right. The explanted and abandoned lead area has come out with a discharging sinus 14 years after the procedure.
So vegetation is there. Yeah. So if it's a lead infection, then obviously you would want to get the lead out at all cost. Whereas if it's a redundant lead, then you might be happy with an incomplete result. So, sure. I think it's time to have one final comment from each of the host and the guest faculty before we wind off. We are very much good in time, and I'm happy this time we had a good attendance. Speaks highly of Amrita's faculty and postgraduates. Happy to do that. Natarajan, you can start with one comment.
Yeah, I once again thank the Indian Heart Rhythm Society for giving us this opportunity, and we look forward to future engagements as well. So I thank you, Dr. Ashish, for considering our institution to be a host in this particular session. And on behalf of our postgraduates, I thank you, because it was a golden opportunity for them, though they initially were a little reluctant. And we spent a lot of time with them, to the extent they regretted that we didn't get an opportunity 2 years back, because towards the fag end of their training, they got this opportunity, but then they were very thankful. So on behalf of my postgraduates, I thank the IHRS for giving this opportunity for their quick learning. And I'm sure it benefited a lot of PGs, and IHRS is doing a commendable job in doing this monthly exercise. Thank you.
I think, Dr. Natarajan, this was exemplary, because this is the maximum number of postgraduates that have participated in the program. So I'm happy that you planned it like that. Sure. Dr. Bhagirath, Dr. Sharda.
Yeah, thanks, Ashish and IHRS for allowing us to be the moderators. It was fun, and it was good to recap so many things from Dr. Natarajan's case. Simple cases, but not so simple actually. So I guess I want the fellows, whoever have attended, to understand that we presented short RP tachycardias, long RP tachycardias. I was thinking maybe a little more discussion on ECGs would have been perhaps of intriguing thing, because especially the second case, I think, where you were discussing atypical AVNRT versus atrial tach, maybe the ECG would have shown a long RP and they would have been more like in sync with understanding things perhaps, but otherwise excellent cases and a lot of easy take home messages. Thank you.
Yes, thanks Dr. Ashish. This was a great opportunity. I think it's a learning for all of us. As they rightly say that every case has a story to tell, every case has a lesson to be learned. And I think the more number of cases we discuss, how much ever we learn from the books, there's always a situation where probably cases like this will help us to make the right decision in the interest of the patient. I thank you for this opportunity. I think I look forward to Narayan Hridayalaya participating also in this program. Please do let us know when the opportunity is possible, and then our team would like to participate.
Sure. And I'll let you have the last word. Praveen, you're there? Yeah, Praveen.
Yeah, thanks Ashish as well as IHRS for giving this opportunity. I will just conclude by telling the whole postgraduates and fellows who are attending that if our postgraduates can do this in a short period of time, it is not a difficult area at all. It is only a matter of time and interest, and you can learn everything by seeing the tracings as well as from the ECG. Thank you.
So well said, Dr. Pai. I think that should be the stimulus to the other centers to come on board with their postgraduates. We of course want the consultants to be a party to this, because then the presentations are more mature, obviously. But this program was uniquely designed to have the postgraduates also on board. And I think this time that purpose is solved. So thanks everybody. We will meet again.
Dr. Ashish sir. Dr. Ashish sir.
Yeah.
Can we have one question? We talked about PPI, TCL and SAVA. Probably the intervals were not discussed. So if we have time, we can talk about the PPI, TCL, the borderline intervals, and where does it fail? Talk about that, Dr. Natarajan.
Since there's a request, one shortly.
Sanjeev, because we were exceeding time, we had to prematurely stop that particular talk. As you correctly said, this quantitative measures during ventricular entrainment are useful to differentiate an AV nodal reentry from an AV reentrant tachycardia, because the pacing is done in the ventricle, which is within the circuit of the AV RT. As we know, an AV reentrant tachycardia using a pathway involves both the atrium and the ventricle, and you are pacing the ventricle, which is closer to the circuit. So, because it almost follows the same pathway as the tachycardia circuit itself, from atrium to ventricle back to atrium in a re-entry fashion, macro re-entry, as Dr. Sharda said. So we are pacing the ventricle, which is part of the circuit, and that is why the VA interval during the tachycardia is the stim to A during pacing is only marginally longer than the V to A during the tachycardia, because we are pacing within the circuit. And likewise, the PPI minus TCL is also lesser than 110. In contrast, the AV NRT circuit is actually within the atrium, involving the slow pathway and the fast pathway, which is far away from the place where we pace the ventricle. So when we do ventricular pacing, it has to ascend up the conduction system, it has to engage the His bundle, reach the tachycardia circuit, and return backwards. That is why the stim to A is much longer than the V to A during the tachycardia, because during the tachycardia, it's a parallel activation or near simultaneous activation. So there is very, very short VA interval during tachycardia, whereas during pacing, it has to go up and down the conduction system and use the tachycardia circuit in the atrium and come back. That's why these intervals are longer.
So the cutoff value will be 85. That's what we talk. More than 85 is towards AV.
That's correct.
More than SAVA.
SAVA more than 85 AV NRT, less than 85 AV RT. The PPI minus TCL less than 110 AV RT, more than 110 AV nodal reentry. That's correct.
Thanks. Thank you.
Thanks very much, Dr. Natarajan. Probably need to
Thanks.
Time.
Thank you.
So the recordings of all this program and the previous program are available on the IHRS website. So the postgraduates should convey to their colleagues if they happen to be busy at this time. Next month, we are meeting on 5th June, and it will be the team from Madurai that's going to present something on tachycardiomyopathy, pacing-induced cardiomyopathy. So again, a very interesting topic. So be there. Thanks for today's faculty for having wholeheartedly participated in the program and making it learning experience. Thanks all.
Thank you.
Thanks, Dr. Thank you.
Good to see you, Sharda and
Yes.
Thanks,
With all my reluctance. Thanks, Ashish. Bye.
Okay. Yeah. Bye.
Thank you.
Thank all the PGs also for participating. Thank you.